Let me just introduce to you this so-called hypothetical session. You may know this already, but my name's Andrew Lloyd, and I'm from the Kirby Institute in Sydney in Australia, and the chair of the INHSU Prisons Network. Um, and we're really looking forward to presenting to you today, you might say, something which I think is best described as somewhere between a drama and a scientific presentation or a traditional conference presentation. And it comes from this a slightly annotated version of the so-called Geoffrey Robertson QC hypothetical, which is this relatively well-known, he is a well-known human rights lawyer, and this hypotheticals format was something that was on television in Australia and other countries, where he would interrogate experts in the field in a hypothetical space to try and make it safe for them to say relatively provocative or controversial things that they would otherwise stick to political script or whatever it might be. So that's the fundamental of this session. If I can, though, I might just start by introducing to you our panellists. I've done myself already, but at the far end, it's a pleasure to introduce you to Matt Bonn, who is a person with lived experience of imprisonment and an international drug policy specialist. Oh, it's all happening at once. I love it. Okay, and then not in order, actually, is all I can say, but let me say down this end is Christy Boswell, who is a nurse by training, academic, and providing hepatitis services in the prisons in the US. Where am I going to next? Tracy Brown, oh, not on this slide. Okay, let me just do Julia Sheehan, who is, stick your hand up, Julia. Julia Sheehan, who I think you might have met already in this meeting. She is our peer worker champion and works for the Hepatitis C Trust in the UK, undertaking peer work in the prisons. And then we've got, back to you, Tracy, good on you. Tracy is a prison-based health service administrator, particularly working in the bloodborne virus space, who can give us the health service administrator perspective. Then Matt and Nadine, who are beside each other there. Matt from the US, who we're regarding in this context as a specialist clinician working in the prison space. And Nadine, who we're branded as a researcher, prisons hepatitis researcher. And then last but not least, the man we're all going to blame for all things that don't work too well, that's Ehab Saleh, who's from UNODC, who's a policy maker in the prison space. And you'll see why we're going to blame him. Yeah, that's right. Okay. I have to tell you, there's one other apology, you might call it a wild card in the format here, and that is our custodial representative, our custodial administrator, wasn't able to make it, but he was able to give me some pointers of things that he thought I should say on his behalf of the custodial perspective of how things work in the cases we're going to, or the case we're going to discuss. Okay, let's get going. Let's get going. Okay, so let me introduce you first of all to the hypothetical patient. So the patient is Jacques, who's a 19-year-old man who's been injecting drugs for several years. And you remember, we're in the hypothetical space, so this is a mythical person who may enter a mythical prison. But the experiences are likely to have some credibility. So he's been injecting drugs for several years, and in the months leading up to his incarceration, he sadly discontinued OAT and was conversely injecting daily, mostly heroin, but also amphetamines. He's been more or less homeless, perhaps related to that same issue. And not uncommonly, he's been diagnosed with post-traumatic stress disorder and major depression, but never treated for either of the above. And he's just been incarcerated for the first time, along with 20 other men who came into prison that same evening. And he's arrived in our hypothetical prison, and it's a state-run, medium security prison, with a relatively small population of around 200 men, that is. This particular prison's got a general length of stay, a median of about 12 weeks. And the average age of the population is about 30 years of age, so a pretty young population. In this particular prison, the health services fall under the banner of the custodial service. So it's a health service within the custodial service. And they sound like they're a bit sparse on the ground because they're all working part-time. That's on the downside. On the plus side, they are offering hepatitis C testing and testing for other bloodborne viruses. There is some OAT available in the prisons, but it's said to be hard to get, and there's no prison needle and syringe program. So that's it for the backdrop. So I'm hoping you have a sense of the journey we're about to embark upon. Because what we're going to do is walk our way essentially through the experience of Jacques coming into this prison and potentially getting diagnosed and treated and so on. And to give you insights into how it works in practice in that setting. So to start the ball rolling, I'm going to leave that as our backdrop. To start the ball rolling, Jacques' been inside for just on 12 hours. And he's just been what my custodial colleague would call processed. That means he's been strip searched, all his belongings have been removed, and he's been put into a prison uniform. In Australia, it's green. In some other countries, it's orange. So a generally distinctive prison uniform. So to start the ball rolling, I might move down to the far end and ask Matt to comment on this situation, because Matt does have, as I mentioned, has some lived experience. And so, Matt, I'm wondering, first of all, what does it feel like to be newly arriving for the first time in prison in going through this process? What do you reckon? Go for it.
Is the mic working? Yeah? Okay. So just to arrive in prison, you're going to feel very distraught. You're going to feel very isolated, a lot of anxiety. It was mentioned that he has post-traumatic stress and depression, but he's never been treated. But I think it's a prime opportunity to provide care to somebody that needs it. But it may be through a peer worker or through somebody with lived experience that they have the best kind of rapport with.
Sorry, Matt, can I just interrupt you there? Because my custodial colleague who couldn't make it today, he told me to just mention about this context. This has got nothing to do with healthcare. This is all about custodial priorities. And the custodial priorities are throughput. Get those 20 guys in, processed and into the system. We may care enough to say we don't want them to fight with each other. We don't want any suicides. We don't want any messy drug withdrawals. But that's it from the point of view of healthcare. What do you reckon? Is that your experience, or what do you think about that?
Yeah, it takes quite a while to actually be seen by a healthcare provider, but I think, it's top of mind for most people who are incarcerated to see somebody. They may just want Tylenol or Advil or Valium to deal with the withdrawal, but, it's the constant dealing with the guards that are coming to check on them. So it's almost a secondary kind of, contact. So it's a guard that's going back to the healthcare saying, well, this prisoner's asking for this. So I think, we could streamline things and have a nurse or a healthcare provider go along with the guard and talk to the prisoners as they are processed, instead of waiting until they, are in serious withdrawal or have kind of committed some additional harm to one another due to mental health or whatever they are dealing with.
Okay, I get it. I think you mentioned, you dropped there the idea that you might be able to get some Valium. I'm just thinking that could be a little bit pie in the sky.
Well, yeah, but I think it's if you have 20 men that are just processed and they're all hyped up, if you give them some kind of anti-anxiety medication, they may be a little bit more receptive to being processed and dealing with
Keep them calm, cool and collected, you reckon?
Exactly, yeah.
Can I jump across to you, Christy, to give your sense? I think it would be common practice in most settings for there to be some kind of a health interaction in the first 24 hours or so. Is that your experience, and what are the priorities?
No. I honestly would love this hypothetical situation where we actually had somebody there to actually intake. Oh, sorry.
I would love this hypothetical situation where we'd actually have somebody in intake at all times, but unfortunately that's definitely not the case. And if there was somebody, I would imagine even if there's 20 people coming in at the same time, it's going to be more of like a quick triage, just are you alive and well, your limbs aren't falling off, you're alert and oriented, and you continue on.
Okay, I've got that, Christy. That sounds like you're working in a bad situation. What can we say about that? Tracy, can I jump across to you? I do know there are some sectors, and I'm pretty confident that you've got experience of some sector where there is a nurse interaction. What would you put on the priority lists for the health interaction at that point? And like Christy was saying, it's likely to be pretty high throughput.
Yeah, it is high throughput. Certainly diabetes, blood pressure, any heart issues, any immediate health issues that, that could actually result in the person, dying or being extremely ill within the next sort of 24 hours. So they really prioritise just the sort of emergency things, Hep C, whatever, doesn't even get a look in until down the track. Drug withdrawal they would look at as well.
What are the chances of getting some Valium?
Oh, maybe. Probably more likely to be put into a cell with a camera than be observed. You might get some Valium for a couple of days.
And without putting words into the mouth of the custodial team, what would they be saying? Would they be saying, suck it up or something?
Oh, yeah, they'd just be saying, let's just process them, for God's sake, let's get on with it.
Okay. So the good news is Jacques survives the first 24 hours. Touch and go, but survives. And we're now moving forwards in time. He's now been inside for about 2 weeks. And he's actually just been called up for bloodborne virus testing. Sounds like it's a good system in this particular prison. And interestingly, the prison's just adopted this recommendation that I think somebody mentioned earlier in the day today. That's this thing called universal opt-out testing. Now, I'm going to go straight to you here, because this universal opt-out testing, that just sounds like complete coercion. Is that what it is?
Yeah. Okay.
Is there a choice in there, really?
Let me try to explain as a policymaker and how we came up with this, because when we start thinking about testing for bloodborne viruses in prison, we had a group discussion, an expert group meeting to decide on this. And we put into consideration the human rights and public health and all of these things, including the medical ethics.
Who's having this group discussion? Are there any prisoners in there? Or?
Yeah, we don't have prisoners there, but we had some medical doctors from the community and from prisons. We have some academia, international and civil society organizations were there. And we agreed that our policy for testing in prison should be in line with of course, the national policy, and also guided by the international standards like the Nelson Mandela rules and Bangkok rules and others.
Okay, the Mandela rules, just remind everybody what they are again.
Mandela rules is the United Nations standard minimum rules for the treatment of prisoners, and it's in talking about the human rights for people in prison. And many of these rules, at least rules from 24 to 35, is focusing on health and responsibilities of health staff in prison settings as well.
So that sounds very noble, but prisoners, they've committed crimes against society.
Yeah.
Shouldn't they just be locked away?
Yeah, but this is a sentence, this is the punishment. Being deprived of the health services is not part of the punishment. They are there for the punishment, not to be punished. And this is actually the policy. And we're following the standards that people in prison should have the same standards of health services as those provided in the community. And this is the golden rule.
Okay, I get it.
Can I have 1 more minute as a policymaker?
30 seconds, yeah.
When we start discussing the opt-out, and I agree with you, I was with you at the beginning that for us to be on the same page, for the confidentiality and for the consent, there's 2 major approaches for testing in prison. One, we call it opt-in, where people say, yes, I want to do it. And the second one is opt out, with people say, no, I don't want to do it. Both are voluntarily, and it's your decision, but we all go, like here, if you read the example here, it says, Jake was called for this, and he can still say no, and that's the point. I would say that opt out, especially for new people newly admitted to prison, can turn out, in some cases, can be compulsory testing, because people who are newly admitted to prison is not powered enough to say no. Even they give the choice to say yes or no, they are not powered. I think personally, as a public health physician, I think we need to explain, provide information, proper counseling, and give the full choice for the person to do it, whether you need it. Our job is to tell them whether you need it or not, if you are vulnerable, if you are at risk or not, and then we leave the full choice to the person to say yes.
Okay.
I hope I answered.
So that sounds very, again, but in the noble category. But Christy, can I ask you, does it actually happen like that in practice?
No.
So what's the loadout?
So where I work out of, no, there's not. It's an opt-in choice. It's a choice, opt-in, but it's not. It's a more recent opt-in option, I should say. This isn't something that the jails, who are run by county, state, or federal, just depending on where you are in the United States, is what you get essentially. When you look at county jails, they're often staffed by like a third party, so you're kind of subjected to what their standards are, what they're offered, how much the county is going to pay the company, and then you also have to look at the individual states, how much they put into their systems, and then you also, of course, have your federal that's run by our national government, so how much money they're willing to put in there. So.
Okay. So I wasn't terribly reassured that this universal opt-out policy happens well in practice. Nadine, I know you've done a touch of research in this space.
I'm a world-renowned researcher, Andrew.
Correct.
So I've done a ton.
Just give it to us. There's such a tradition of coercive, involuntary medical stuff done on prisoners back in the day that we have to overcome to make this work in reality well. How can you do that?
Well, I just think we need to go back to the basics on what the definition of coercion is. And something is considered coercive if there is no other alternative. So when you're offering opt-out screening, you have the option to say no, and therefore, by definition, it is not coercive. My research has shown that the way to screen individuals at mass numbers is through universal opt-out screening. The second best approach is opt-in, followed by on-demand screening, i.e. someone makes that request. You could imagine that in a prison system, offering testing to everyone and then allowing them the choice of saying no is not coercive, but actually screens the highest number of people, and hence has made it into global policies and is considered the global standard going forward in all carceral settings.
Okay, I'm semi-convinced. I'm wondering, Julia, can I ask you, in practice, peer working is your role. I wonder whether we could ease the angst about this coercive interaction that's going on here by having a peer worker in this engagement.
Yeah, most definitely. The peer worker would be like the kind of in-between person and could definitely encourage the JACs to say yes to a test. I guess explaining more the reasons why, a bit about treatment, and why it's so important to have a test.
What would you say, Julie? Give me the gist of the spiel.
So we would talk about the risks.
The risks of the test or the risks of the disease?
The risk of Hep C,
Right.
of transmission routes, see if they've put themselves at risk. We would talk about there being very few symptoms, and that there's an available cure.
Yeah.
So we would talk through that pathway with them.
It sounds like a pretty easy sell in a way, but I know, Matt, or my experience, and I don't know what you're thinking about this, but there's a sort of a pretty common intrinsic distrust of the health system and medical providers, and that's all just heightened in the prison space, I think. What do you reckon?
Yeah, I agree. I think most people that have been incarcerated have, distrust within authority, let alone, health authorities. So, a lot of times people are taken to the emergency department in handcuffs and, forced to be seen by a doctor before they get processed. And it's just not the best setting, So I think, having somebody that can say, I've been there, I've been where you've been, I have hepatitis C, I've been tested, I've been treated for it. I am someone who uses drugs. It just builds that rapport and, it builds that trust and, puts a little bit more of empowers the person to make that decision a little bit more easier.
Okay, I think we've got a pretty good description of what we might call the best practice standard of how this testing universal opt-out interaction should occur. Tracy, can I pass over to you just to ask about the logistics? So you might have noticed that the plan here was timed around 2 weeks post-imprisonment. Do you think that's a suitable time? What's going on in the lives of the prisoners, and what do you reckon? What's the best time?
Yeah, I think for bloodborne virus testing, certainly in Australia anyway, it needs to be a couple of weeks down the track, unfortunately. I think when they came into reception, it's a very stressful environment. As you said earlier, they've been strip searched, everything's been taken off them. They may have been locked up in a cell in the police station for 2 days before coming in. And we've found that they're not really receptive to testing and a lot of health questions. That's just what we've found. And so we normally put it off for a couple of weeks until they've sort of settled down into their cell and, they've had some contact with a nurse or the health service to, just try and build a little bit of rapport before you start sort of, hounding them about testing, etc.
And Matt, is there a counterbalance against that? Because that 2 week time point, that sounds like that's most of the duration of stay in the US jails.
So the median length of stay is in and around a week in U.S. jails, and in remand prisons really, really short. So to wait that long, you miss an opportunity to screen people early. And so there are options with screening in an opt-out fashion, point-of-care tests, antibody tests versus RNA tests, really the favored one. And you can do antibody tests to start, but to get an RNA test done quickly is really, really of utmost importance so that you can get people counseled and get them on treatment if they need it.
Okay, so you flagged there that point-of-care testing might be a strategic approach to doing this BBV testing. But again, Tracy, from the point of view of the health administrator, point-of-care testing, can we multiplex and do every test we damn well need to do?
Well, we can't do every test we need to do, but one thing we might be able to do, which we're looking into, is if we're testing for diabetes, that's a finger prick test. Why not do a 1 minute INSTI antibody test at the same time?
Not mentioning any trade names?
No, sorry. No, why not do a quick antibody rapid test at the same time using the same blood draw from the mini-vet, and at least then if they're antibody positive, then you can, in our system they would then be waitlisted for a point-of-care test or a phlebotomy.
So just for everybody, so we're on the same page, there's a finger prick, there's a little mini vial, which we call a mini-vet, that might be the vehicle into which you collect that small blood volume sample.
Yeah, well, hopefully you could get enough blood from that one vial to do the diabetic test and also an antibody test as well.
So Matt, can I just ask you, I don't know if you have any direct experience with this, but point-of-care testing, that sounds like some latest fandangled test that may or may not be reliable. What do you think? Would it go down well, or is it okay?
I think with the right education and information that you're passing on to the people who are incarcerated, it could go down practically pretty well. And I think it's better than going right for like a phlebotomy test and a very invasive test.
And why is that? Why phlebotomy? That's just the way all tests are done, isn't it?
Well, yeah, but like if somebody's been injecting and they've been using drugs, maybe they don't have as many veins as they used to, and maybe they're just not as comfortable kind of with that kind of route of administration of a test. So having something new and innovative, I think, that
Could be good.
Could be good, yeah.
It sounds like it requires a bit of education. I'm with you. Okay, we're doing well here, team. We've made it through bloodborne virus testing. Great progress. So Jacques' been diagnosed through that bloodborne virus test with chronic hepatitis C. And while in the presence of a custodial officer, that's the same guy who's absent here, I think, today, but anyway, he's present, and he's been offered a referral to a prisons-based hepatitis service, but Jacques says no thanks. And that's because he's anxious about what it means to have chronic hep C, and he doesn't trust the prison hepatitis service in a month of Sundays. And that's because he's had some outside experience which wasn't great with health services. Particularly, he went to some bloody gastroenterologist in their rooms and was treated pretty badly, to be honest. And so he's been a bit scarred by that experience. So we've got a challenge here, team. How are we going to help Jacques overcome that traumatic experience? So again, Julia, I'm wondering, there's got to be a role here.
So, yeah, Jacques clearly needs support and an intervention. He needs educating. He might have fears around the old treatment and isn't too up to date.
Like interferon-based treatment?
Yeah, it's got such a bad name and it still kind of hangs about like a bit of a black cloud. So yeah, just given information and empowered to make that decision for himself, and also lived experience, sharing that maybe they've done the treatment. That's quite powerful.
Yeah, so is that, I'm just trying to picture how this works in this high throughput context of the prisons. Does that mean you just arrive when the result is available and participate in that, I don't know, what we might call post-test counselling and referral? Or do you have to do preliminary work, do some groundwork?
So in my prisons, we work very, very closely with healthcare, and we will be included in the referral. So if somebody just doesn't turn up to clinic, so that they're referred or even refuses to even be referred, we will know that and we will go and have a chat with them and just see. Sometimes it's just having a bit more information and yeah, just a talk and talking it through.
And are you convinced by that spiel, Matt? Do you think a peer worker, somebody like Julia, can be trusted by a newly incarcerated inmate?
I think it all depends on their relationship and, you know, that first interaction, but I think, yeah, it certainly provides an avenue to trust somebody that's not a healthcare professional, that's somebody that has lived experience, somebody that is a peer worker. I think it definitely provides an opportunity, for sure.
Can I just add something as well?
Sure, go for it.
So even better, we would get volunteer peers, maybe. We wouldn't send them straight to you or to Jacques because that would be a breach of confidentiality, but we would give Jacques that opportunity to maybe speak with them.
Yeah.
Or so that he's aware that there's hepatitis C volunteer peers.
Yeah. Now, I'm broadly aware that a lot of what happens in the prisons is very dependent on the custodial staff. So if the custodial staff don't want to call Jacques or any individual up to the clinic to facilitate this interaction, it may well not happen, and they won't necessarily disclose that they're the reason that it didn't happen. They just may not like Jacques too much and want to have it in for him. So I'm wondering about that sort of, what I guess is a discriminatory thing from the custodial staff. I'm wondering about how we manage that. Julia, do you want to take a whirl?
We call the wings from the clinic space and ask why they haven't been unlocked. And
what does that mean? Call the phone?
We'll call up the house blocks, the wings, the spurs, and find out why they haven't come. And
can you get the lowdown really? Isn't it the wing
yeah,
officer that answers and says,
yeah,
of
it's
course.
not as easy.
Jacques
They don't
didn't want
answer
to come. He
phones,
said
short
no.
staff. Or we'll go over there.
We'll
physically go over there.
Okay.
Myself and a nurse will go over.
This sounds like patient-centered care or something.
Yeah? Wow. Yeah. Who knew?
What about that discriminatory sort of attitude, not necessarily restricted to custodial staff, I might have to say, sometimes healthcare staff and between prisoners. I wonder about how we're going to overcome that sort of stigma and discrimination. Nadine.
Oftentimes, the stigma and discrimination is due to lack of knowledge around hepatitis C. And at least in Canada, there is a hepatitis C training course that's online for all correctional employees, done at the time of admission, 30 minutes online, never done thereafter, never updated, and that's all the exposure most people get to hepatitis C. There's a phenomenal study in Australia called HepEd, whereby there's whole of prison education, cognizant that, you know, believe it or not, there are going to be healthcare workers that don't have the knowledge that you would expect. And so there's whole of sector education, whereby there's champion inmates, there's champion healthcare workers, and there's champion correctional employees that are trained and educated in hepatitis C, and then they then go and treat their colleagues and peers with the goal of mass education such that we destigmatize hepatitis C and get everybody tested and treated. So education is really the way forward.
Christy, Nadine just cast aspersions on some of the healthcare staff there. She said they don't all really know or understand Hep C. What do you reckon? Is that true?
Yes, 1,000%. Yeah, I've had several nurses that we work with, you know, say, oh, isn't there a vaccine for that? Or are they not still doing interferon? This is crazy. And I'm like, no, it's cool.
We've moved on.
We could actually move on from that. But yeah, there's a lot of still misinformation out there. So I do make it intentional to talk to people about, you know, what the treatment options are, how simple it is, especially if I'm leaving that medication there for the patient, for the nurse to help, you know, administer those medications, just letting them know things to look out for, what would alarm symptoms be, what medications they can't give with the medicines, all those different kind of things.
Okay, we haven't actually got him through the door of the hepatitis clinic yet, but we're getting there. Can I tell you that Jacques is actually transferred to another prison, because this is a statewide prison system, and the custodial team like to move people around reasonably regularly, keeps them under better control. After a few weeks, the good news is Jacques engages with a peer worker in the new facility, and who manages to improve his trust and gets him to the hepatitis clinic. Now, Ehab, I wouldn't like to paint you as the villain here, but this clinic, it's all about working up and then providing DAAs. But DAAs for prisoners, do they really deserve it?
Yeah, of course.
Okay.
Of course. Yeah, they do deserve it, and without any discrimination. And I mean it.
So that's probably what Nelson Mandela said, so that's good.
That's
Is there any
right.
other more tangible benefit?
Yeah, there's nothing would stop a person starting the DAA in prison, regardless. And I can say that before we put the policy for this, we start to see other experiences. And you see some countries, they have a problem with people with short stay in prison. No, it doesn't worsen staffing. People have a problem with foreign prisoners. No, it's not my responsibility, I take care. No, the policy is to start for any and everyone who is in need, and it started immediately and as soon as possible.
Okay, the principle sounds good. If we work with that principle, I guess one of the things you might say as a potential benefit is that treating in prison might help the community at large. Do you believe that notion?
That goes without saying. And for me, that's my slogan, which is prison health is public health. But first, there's something here that when we talk about prison and we take care of the prison because of the community, no, it's a prison first, the people in prison first. So the person first, it's a people-centered approach. Then the community, the staff, the family also will benefit from this. But we also care about the person and the rights of the person.
And if you're talking to the custodial workforce, what's in it for them?
for them, for the staff working there.
Yeah, what's in it for them to get the prisoners treated for Hep C?
It's an integral part of the work. It's not an extra work to provide healthcare service.
Oh, yeah, but they've got to bring the bloody inmates up from the wings, you know, and they're busy.
And this is a way to do it.
Okay,
This is a way to educate them.
okay,
It's to reduce the stigma and discrimination, with the most and the major barrier for accessing healthcare services.
okay.
is
So a bit of education, bit of
education,
attitudinal change.
communication, peer education programs, behavioral change.
Okay. That all sounds very good. Tracy, can I come back to you? It's not a straightforward issue, is it, in general, to deliver healthcare in prisons, I guess, full stop. Talk to us about the logistics of how you might make this work.
Well, as you said, unfortunately, there's huge amounts of movements, and especially in Australia, we have private prisons and public prisons, so people get moved all the time in between the two. So what we really need is electronic medical records. We need to be able to have those records available to everyone in private, public, any nurse in any prison, regardless of where that patient gets transferred. And, I think in New South Wales, 9 times a year is the average of how often someone gets transferred. So, we need electronic medical records and electronic medication charts as well, because we also find a lot of people get transferred. They may have, like Jacques may have had his bloods done before he got transferred, but those results aren't with the new prison, so we're back to square one. Or he may have started treatment, gets transferred and the treatment doesn't go with him. So, we need to make sure that and then we also need that, in the best practice world, we'd have the same medical records that we have in community. So when they get released, then all of their information is still available to whoever they see in community as well, so they can continue.
Matt, from the specialist physician point of view, Jacques had a bad time with the gastroenterologist. That's because he wanted to do a whole heap of tests. It's a pretty complicated affair.
You should have
to get
seen
onto
an
treatment.
infectious diseases doctor.
Not an what else needs to be done apart from making the diagnosis with an antibody and an RNA?
So it's so much more simple now. The medications are so well tolerated and so easy to take. I think, task shifting, making sure that people are empowered at all levels of care to deliver and treat. So nurse-led models have shown great success. In the United States, physician assistants are very good at treating primary care. We need to expand the workforce to be able to provide DAs at more points of care, and this also applies within the correctional systems.
Okay, got it. So the good news is Jacques is now ready to commence DAA therapy. He's had a few tests, not too many, and it all looks pretty straightforward. The only spanner in the works is that Christy got enthusiastic and ordered some hepatitis B serology. And perhaps surprisingly, the hepatitis B markers were all negative. And so what should we do about that, Christy? Immunise or?
We would definitely immunize, but luckily he's also negative with an active hepatitis B infection or a latent,
Doesn't have chronic Hep B,
Yes. So, yes, definitely would immunize if they were actually available within the system, and they're not. There's a lot of regulation behind just vaccine storage in general, just like temperature, transportation, if one's lost, all those kinds of things. But also just there's lack of funding to actually obtain these vaccinations and those kinds of things.
And so Tracy was flagging in her system, at least, the individual prisoner might move 9 times a year.
Yep.
And there's a schedule, it's like 0, 1 month, 6 months. Is that going to work in this 9 times a year rotation?
No, it's not.
Okay.
Yes, so trying to give, like when we go back and see patients, I do try and hand them labs, like give them a contact phone number, some way for them to have at least some way to reach out either to me to help facilitate their record transfer, but.
Did you catch that, Matt? So Christy has just given to you a hepatitis B surface antibody, core antibody, and surface antigen test result on a piece of paper. Can you interpret that okay, or?
As a prisoner, I would have no idea what that was. So I think, having that education or having the peer worker along with Christy would be extremely helpful.
Okay. Okay, so it sounds like Christy's keen to sort of empower the patient to make sure they get continuity of care, and I guess Matt and Julia are saying we should make sure that peers are there to support that process. That all sounds not perfect, but an acceptable compromise. Matt, can I come back to you? So we're at the moment now of choosing a DAA regimen, and that's pretty damn complicated, isn't it? There's all these drugs that are a problem, and
It used to be, but we've moved on tremendously. About 10 years ago, there were a lot of options that the number of options have been whittled down dramatically. So now really there are mainly two regimens, both very easy to take. Some of the main differences, especially for jail and prison settings, remand and internationally, is the length of stay. So there are regimens that are of 8 weeks duration, regimens of 12 weeks duration. It may be beneficial to select the regimen that's shorter in a remand setting or a jail setting. But all in all, these medications can be dispensed through very great methods like directly observed therapy sometimes in certain facilities, also to be taken from the pharmacy, and they're very, very successful for the most part. One major challenge, though, is upon discharge and the competing priorities that people face after incarceration, active substance use, homelessness. And so those things need to be fortified, and wraparound services need to be provided to support people in the transition back to the community.
we sort of glossed over a little bit there, but does fibrosis stage come into the treatment choice?
Very little at this point. So beyond advanced cirrhosis or decompensated cirrhosis, the regimens are basically the same. If there is cirrhosis, it is a benefit to have a specialist involved, so that if there are complications of advanced or decompensated cirrhosis, that they can get the care they need.
Okay. So Jacques is initiated on his DAA therapy. He's been taking it, and he's still inside because he was denied parole at his hearing, his parole hearing, and so he stays a bit longer, perhaps fortuitously, than he would usually have anticipated. And what he says is, yep, Doc, yep, Christy, I'm usually taking my pills, and his good news, he's had 1 dose of the Hep B immunisation schedule. That's the good news. I don't know if it's bad news or good news. Good news for him, he's getting out in a month. But he's still got 6 or 8 weeks of medication to go. So maybe to start the ball rolling, Christy, when Jacques says usually, it sounds like he mightn't have stuck to the treatment. Hasn't been taking all the pills like he's used to. Does that matter?
Of course, we encourage people to take their medications and not miss dose, but we all do forget at times. And these medications generally are okay if you miss a day or two. If they do miss, obviously re-educate on the importance of adherence, but also there's very simple algorithms you can follow to figure out what your next steps are, as far as do we need to redraw his blood, all those kinds of things.
And I think Matt flagged something about observed therapy, as in watching the patient take the pills each day versus giving them a week or a month's supply to take to the cell. Is that, what do you think? We should make sure everybody takes watched every day?
No, because these are very safely taken. They don't, there's no psychoactive component to them. They are, there's no real street value to them on their own.
Can't you crush them and inject them or something?
No.
Right. Okay. Okay. Can I ask Julia, what, in a practical sense, what's your advice about this issue of managing missed doses? How do you, or maybe up front, what advice would you give about how to make sure you don't miss doses generally?
So we would speak to the patient and explain the importance of taking the medication.
But what does that mean in practice? Take it after you brush your teeth or something, or?
No, maybe take it at the same time as other medications you
Okay.
take. And we'd really try and support them with that. If they've got it in possession, we would ask them, would you rather have it at the meds hatch so that you don't forget? So we would give them that choice.
What was the terminology there? Rather have it as? Med sash or something?
The medication hatch. If they go up to
Go
get
up each day and directly observe therapy.
Yeah.
Sorry, so I interrupted you there.
No,
you asked them, would they prefer to do it that way?
Yeah, to give them that choice.
That's a bit of an insult to intelligence, though, Matt, isn't it, for them to say, do you want to come up to the gate? It's pretty cold. Could be somewhere in the north of America. There's snow outside. You have to go up to this damn hatch and get your pills.
I think it makes sense to give the option to the person that's in prison. Maybe they're on opioid agonist therapy and have to get daily witness medication anyways. So
Yep.
you could pair that along with that to just ensure that they are taking the medication at the same time every day.
And from the health service point of view, Tracy, do you have strong feelings about one way or the other? Should everybody get supervised, or is that a bit of a logistical challenge or something?
Well, it's an individual case by case. So basically, we would just ascertain whether the patient was capable of taking that medication by themselves. Maybe someone with an intellectual disability or someone with a mental health problem, we might think that probably they're better off going up each day, but we would assess each patient individually and make a decision on that.
And in practice, if you do that, I'm broadly aware that that's how it works in your system. What proportion of individuals would be receiving their pills either weekly or monthly versus directly observed?
Oh, look, I don't know off the top of my head, but I'd say around about 80% would be given their full 2 or 3 months at the one time that they keep in their cells. That way, then if they do leave or get transferred, at least they can take their medication with them.
Just one note on directly observed therapy. I am all about choice. I think that's really the most important thing, but it's sometimes not the trust of the person, but trust of the system. So making sure someone's actually able to get the medication on a daily basis and that it's not taken in a raid or there are other extenuating circumstances that can actually benefit the treatment to ensure that the person is getting it. But I do think choice is the most important.
My custodial officer, missing member, who's gave me some pearls of wisdom about things that he would like to add to the discussion, told me that really in many ways Hep C treatment, it's a surrogate for working out who's using. And so do you think there's some stigma associated potentially with having to come up to the what was it called, the hatch? The hatch each day to get your pills and telling every other inmate and custodial officer that you're taking Hep C treatment and therefore you're a junkie?
I mean, I think as Matt said, people who are taking OAT, there are other things that are being given directly observed, and in some systems there are other medications that are directly observed as well. So I think it is fairly destigmatized to be able to go to a window and people don't necessarily know what you're taking. So.
Do you believe him, Julia?
Prison officers should not be privy to that information. It's really important that they're not.
But there's an unnamed medication that's got in a quite big box that's too big to stick in your pocket if you're getting a month's supply. So how do we, the word spreads pretty quickly.
So if prisoner has worries about that, then maybe it should be their choice to get it from the medication hatch.
Okay. So the good news is Jacques finished his treatment. That's the good news. The bad news, he's still inside, struggling to get out, and he's still RNA positive when he's tested a month or so after the end of treatment. And he mentions that he's been continuing to use whilst taking his anti-Hep C treatment. And in particular, he's been injecting methadone. We won't mention how he came to access methadone, but at least a couple of times a week since he's been inside. And in this particular prison, tattooing's an illegal behaviour, so it's illicit, and so it's generally done with illicit sort of devices, and he's been tattooing like all good prisoners do. And he's also a little annoyed, it's probably a mild way of describing it, because he's been trying to get onto OAT because he recognises he's opioid dependent. And on several occasions he's been knocked back. He's got no space on the OAT program. And he's actually been told he's not opioid dependent. And to make things worse, he's been trying to do the right thing. He's been trying to clean his fit, so he's been washing it out as best he can each time between uses. But he's in a bit of a bind because every time he wants to use, he needs to get access to drug, and the only way he can do that is to trade the fit for the drug. So he has to share to be able to access the drug. Nadine, can I ask you, do you think that's a common scenario of the circumstance of injecting drug use in the prison environment?
Yeah, so what we know about injection drug use in prisons is that while it may decrease in terms of community prevalence, it's done much more in a high-risk fashion. What that means is that people are sharing needles much more in prison than they are in the community. And that's a sheer result of the fact that there's very little access to clean and sterile syringes. So you can imagine there's, that one odd needle that's being shared among a group of individuals, some of whom may have HIV or hepatitis C and risk transmitting it to others. So it is a common scenario, certainly not to be underestimated, and that same needle is actually being used by many to perform tattoos. And the prevalence of tattooing is actually thought to be even higher than the prevalence of injection drug use in prison, with the most recent data about 60%. But if you speak to anyone within prison walls, they'll tell you that it's close to 100. So it's a common phenomenon, and one that needs to be addressed to prevent transmission of infection and reinfection.
So I'm catching up that you're advocating for sterile tattooing equipment to be made available. How's it going to work in practice?
Yeah, so interestingly enough, I just learned actually that Luxembourg is the only country in the world with a safe tattooing initiative. It's been in place they have 2 prisons. It's in place in 2 of their 2 prisons. They're opening up a 3rd, and that will be the goal as well. It's actually run by individuals in prisons. So individuals in prisons are trained to do the tattoos. And when individuals who are interested in tattooing or getting a tattoo, they get an educational session by their fellow colleague who's been trained in tattoos. They're paid by that individual for the tattoo. It's done in a sterile manner, and they go on their merry way in a sterile fashion. Canada unfortunately had a safe tattooing initiative that fell by the wayside, and sadly it's not on anyone's global agenda, although it is it's thought to be one of the 3 main pillars of harm reduction in prison. So stay tuned. I don't know if there's going to be much activity. In terms of priorities, I would say OAT number 1, PNSP number 2, and then safe tattooing number 3. But if you ask people in prison, they may not rank order them the same way, given how many are actually tattooing each other. They may actually say safe tattooing initiatives number 1. More research is certainly needed in this area.
So I love the closing line, or more research is needed. What is actually the evidence base for OAT and PNSP in reducing hepatitis C in prison?
Thank you for asking that, and I'd love for our policymaker to also comment. So
yes, we're going to ask what you have next.
There was a recent paper published in IJDP, and I'm sorry I'm sounding like such a researcher, but it was presented a year ago at this very conference. It was a review of reviews that updated a systematic review that was done in 2014, and it found an insufficient level of evidence to suggest that PNSPs or OAT reduce the transmission of hepatitis C in prisons. Insufficient evidence. There is no good evidence to suggest that these programs do work. However, they do work in the community, and one would argue that there's no reason why they wouldn't work in prison. Is the evidence needed? One could argue no, because they work in the community. One could argue yes, because policymakers often ask for the evidence. But if you think about it logically, just stepping back from a common sense standpoint, you're giving someone OAT, so they are by definition decreasing their injection use, and then you are providing them with safe, clean needles and syringes, and therefore supplying them with a safe supply. From a common sense standpoint, decreasing injection drug use plus the provision of clean syringes means that there is a decrease in hepatitis C transmission. So from my standpoint, no evidence is necessary. It's logical, and it's been proven in the community.
Do you buy that, Ehab?
Yeah, of course. I think my distinguished neighbor here. Yeah, I know you're talking about a published article on this and all of that, but there's other evidence supporting that. OAT, opiate agonist therapy, and prison needle and syringe program is contributing to the reduction in transmission of bloodborne viruses in closed settings. That's one. And second is, as you said, and this part I agree with you, that it's also important to think about these interventions as one of the human rights. And this is all, we always forget that we need to think about humans and the human rights. And these people, they have the right to access these interventions. And it's a variety of intervention that they need to choose from. It's not one size fits all, and we need to provide everything as in the community for them, and they decide. Same for the tattooing and the availability of sterile equipment for tattooing. Again, you can tell me that I'm a prison warden and I don't have tattooing in my prison. Put it there, make it available, and let them decide for this. What we know, what we think we know, might not be the reality on the ground. So this is why we promote that these interventions to be available in prisons for the prevention of bloodborne viruses.
Thanks, Ehab. Back in the noble non-villain category. Okay, we're going to move on just a touch. Tracy, early on in the piece, the scenario described that Jacques, who's been inside now for at least 4 or 5 months, and he's been injecting opioids 3 or 4 times a week, and he's just been told he's not opioid dependent. How on earth can that be true?
Yeah, I don't get it. What we'd be doing is we actually have a referral pathway with drug and alcohol for people that we're treating and retreating for hepatitis C. So we would be getting our hepatology nurses to contact drug and alcohol and putting forward a very strong case that that patient be reassessed for OAT.
Driven by the reinfection episode as an argument for, or?
Driven, for us, it's driven by the reinfection episode, yes.
That's assuming, Matt, it's reinfection. Could be just treatment failure, couldn't it? What do you think the probabilities are, and how do we negotiate that?
It's actually tough to tell empirically, because the only real way to do it is through phylogenetic analysis to see if the strain that the person had before treatment and the strain they had after treatment are the same. You can also do it using genotyping. So if the person initially had one genotype and has another, then that would suggest that they've been reinfected with another strain. But that should not hold up treatment for this person. There are regimens that are available for reinfection. And we can assess clinically if someone has been adherent enough to their treatment, they've taken enough of it, and they've become undetectable. You can presume that they likely achieved SVR, even if you don't have the 12-week time point, and potentially treat them again as a reinfection with the same regimen. The regimens for treatment failures are not that much different. Also single tablet regimens, sometimes a little bit longer with the same regimens, but equally effective and equally safe. So no one should be denied treatment based on the possibility of a reinfection versus a treatment failure.
Okay.
Yeah, and I just say we retreat. About a third of our treatments, we do about 1,000 a year, about a third of them are retreatments. We're happy to retreat.
As in no barrier to just move
No
straight on
barrier
and
at all.
retreat.
It just gives them an extra foot to get in OAT.
Now I'm still a little bit worried, Ehab, about providing this expensive DAA treatment, which we've swung around to the idea we should do it, but we're doing it without concurrent harm reduction. Is that crazy or what?
So you're saying that we provide the
Here's a
expensive
guy who's just finished his DAA treatment,
Yeah.
and he's become, we presume, reinfected. Wasn't it stupid for him not to be on some kind of harm reduction intervention concurrent with his initial or at least his retreatment?
No.
Don't do it?
No, he should be.
He should be.
Access to harm reduction interventions, definitely.
Okay.
For me, it's no discussion.
And so what does that mean in practice? What do you think? They don't have a prison needle and syringe program.
I don't know about the practice. I'm a policymaker, and I leave the practice to our police.
So the practice, Tracy, what should be happening here in practice?
Well, in practice, he should be given all of the information around harm reduction that he can. And, you know, if there's a prison NSP, well, that's fantastic. If not, then he should be given all the information around cleaning syringes, the use of disinfectant or bleach if that's available, whatever you have that is available to him, he should be
So
made aware of.
you've just mentioned something there that I've got the suspicion is in an evidence-free zone, that is bleach as a prevention measure for Hep C transmission in prisons. Is that, what do you reckon, Nadine? Bleach, do anything?
The Aussies call it Fincol, do they not?
Yeah, well, it's a
It's disinfectant.
Yeah.
So interestingly enough, I think the Tracy's of the world and the health administrators of the world think that that's a sufficient harm reduction measure to provide to their population, and can sort of, you know, wipe their brow and say, we've done enough, when in fact, there is actually no evidence to suggest that disinfectant, Fincol, whatever you want to call it, actually suffices as a mechanism to deactivate virus in a syringe. So it's actually not included in any of the UN packages for harm reduction. It is unfortunately in the Canadian package, but again, I think it's to make everyone feel better about themselves rather than truly mechanistic.
So Jacques is keen to explore another prevention strategy. So he believes that the guys he injects with, his sharing network, that he might have got Hep C from one of them, or got reinfected from one of them. And he's in the noble spirit category. He wants to give them some advice. So he's thinking, I might just disclose. I was infected, I got treated, and now I'm reinfected, and I think one of you damn guys gave it to me. Do you think that's a good idea, Matt, for this Jacques to fess up to the fact that he's been reinfected from them, or that he might have been the source for them, potentially?
No, I think he has to really put it on the system, and, you know, on that it's not the prisoner's fault, that it's actually the institution's fault for not providing needle and syringe programs and access to OAP.
Do you think his injecting network will buy that?
I don't know if they will, but I think if he could convince them that, you know, having needle and syringe programs are beneficial to them all, then I think they'd all be in a healthier and better place.
I didn't describe Jacques in physique, but I'm picturing him as a pretty slim, small guy. He's not really keen on tattoos, and his injecting networks, they're all bodybuilders. And so I'm wondering whether he's at risk of getting belted up here.
You know, I think you're always at risk of getting belted up in prison, especially when you're talking about infectious diseases. But I think, you know, if he could provide that education, like if you're going to beat me up, you know, and I have hepatitis C, you know, that it could be a route of transmission. So
I like it. It's a good line.
It could be some education piece there.
That's great, Matt. Julie, do you reckon there's a role here for peers to do some, let's call it group-based education?
Yeah, definitely. Delivering some kind of awareness training, preferably around Hep C, Hep B, and HIV, transmission risks. Also, maybe delivering promotional materials, information leaflets, and maybe liaising with staff and doing some kind of testing event.
Testing of the network kind of thing.
Yeah.
That sounds like an interesting and good strategy. And do you think, back to you, Nadine, is there an evidence base that suggests that testing and treating widely might actually be a prevention strategy?
Andrew, I think you may have led that study. The infamous Stop C study, that's probably one of the, you know, will be the most quoted study in hepatitis C transmission in carceral settings. It showed that mass testing and treatment of people in prison led to a reduction in the incidence of hepatitis C. So the notion of treatment as prevention, treating someone prevents other individuals from becoming infected. And so that piece of work is really going to, I hope, drive and accelerate the policies in many carceral settings worldwide for universal access to treatment.
I guess, though, we were talking in part about what you might call a network style treatment as prevention. So just treat the network. Has that got plausibility? I don't know. Is there evidence for that, do you think?
You know, it makes sense that you would treat the network, but the networks change in prisons. The networks, different networks form. People who never injected begin injecting. And so while it seems feasible and plausible on paper, the reality is that a whole of prison treatment as prevention is bound to be much more successful than a network that we presume to exist that is likely much bigger and wider than really exists.
Okay, we're coming to a culmination here with our ultimate challenge, and that is post-release care, because Jacques' now on a salvage regime and he's done halfway through, so he's got about 6 weeks to go. That's the good news. The bad news is he's getting out tomorrow. And he's not sure what's going to happen to him on release. Remember, he was homeless on the way in, and he doesn't have much of a good social support structure. He's got some injecting mates on the outside, but not much else. So I'm wondering, first of all, Christy, about how we're going to manage to help him to get at least his Hep C retreatment completed and ensure continuity of care.
Yeah, so typically what I try and do is start essentially discharge planning from day one, right? So get them prepared for their release or their transfer as best as I can. Oftentimes that is unknown because we're waiting on, court dates, those kinds of things. But that's why it's important to figure out what their social support is, even if it's maybe not a family member or even friends. Maybe it's just like an organization that they have a plan to go to, or maybe it's just connecting to them and saying, hey, this is a safe place as another healthcare provider for you to go and see, just being part of that like known connection to them to help them continue on their care.
Do you think that's enough, Matt? What do you think about that, in terms of transition care, pointing them in the right direction? Sorry, Matt.
I think that could be for both Matts. But I think that I agree with Chrissy. You need to start early. You need to have as many services and touch points as you can. So you need to be having, have information about the person's family that can get in touch with the person, make sure that they're supported in terms of their housing, make sure they're linked to OAT upon release, and just provide as much wraparound support as possible.
Yeah, sounds good. Ehab, can I come across to you? We've been pretty focused on the hepatitis story here, but in many ways the Hep C may be the least of the worries for this guy. So what else do we need to get in place for good post-release care?
This is very big question and very complex situation. The first thing I would like to talk about is the prevention and management of overdose mortality due to drug-related.
Okay, in practice, what would you recommend in that context?
Proper training to all the people trained, what we call it the pre-release training program.
So to the healthcare staff?
And civil society organizations.
And what about the prisoner?
Yes, he would be one of the people receiving the training.
And
to be trained.
So what does that mean, naloxone training or?
Yes, we need to train people on people released from prison and give them enough time. And for those who might witness an incidence of overdose incidents, to train how to use this, how to use naloxone, whether naloxone nasal or IM. And this is very important on how to train on how to deal with a situation of overdose. If it happens, first to prevent it from happening, and if it happens, how to manage the situation. That's one. But this is one among many other things. We recognize the role of the civil society organizations in bridging the gap between the prison health and community health. However, we know they can do this, and they are doing it in many countries. But the point is, we still have a lot of challenges, major challenges, I would say. First, of course, is the stigma and discrimination. And the worst is the stigma at the healthcare facilities in the community. If you think about a person using drugs, living with HCV, and former prisoner This is the triple layers of stigma, and that make it difficult. And for me, it's difficult to swallow that stigma is available at the healthcare facility where they should provide the services. That's one. And the second is, you will see that the prison health authority stops at the prison door, at the prison gate, where they should deliver this to another administration to take care of the person, and they don't speak to each other. The coverage of insurance is a challenge in many situations as well. So we have many, many issues. And the problem is also, I'm not sure about Jack and what kind of the quality of services he received when it comes to rehabilitation and social reintegration. So in many cases, you'll see the people released, they want to disappear.
Can I just mention, Ehab, you used the word prison and rehabilitation in the same sentence, I think. Does that ever happen, actually?
Yes, to some extent, but I would say that, yeah, I got your point, Andrew, and yeah, of course I see your point, but the quality is always a challenge or a question mark. We need to focus on the quality and also the prevention of recidivism in many cases. Okay. I don't want to see Jack in the prison anymore. So.
Okay. I think we have explored Jacques and his story very well, and I hope in this session you've gained some hands-on insights into the nitty-gritty of what life is in the prison setting, and some pearls of wisdom from all sorts of stakeholder groups here. Can I just remind you about INHSU Prisons, and if you're keen to get involved, please make contact with us. Can I thank very much all of the panelists who donated their time. Fortunately, it wasn't me asking the questions, it was Jeffrey Robertson, and so I'm not to blame for all the controversy that we generated. But thanks again, everybody.